So, what are you all here for tonight? The great hormone conversation you've been waiting for. First, let me acknowledge the six men who are here. This is important for men to understand, to know what their daughters or their wives or their girlfriends or their mothers are going through during a very important time in those people's lives. Not only do we have men here, but we have Boyce, who is a 4-month-old young girl who's starting her education on perimenopause and menopause very, very early. And there she is. I am most impressed by her presence. So, thank you for coming, Boyce. We hope this is helpful as you grow. Okay, my name is Altman. I'm a gynecologist. I was trained in New York and Boston, had a practice in Boston for about 30 plus years. And right now, I call myself a consultative gynecologist for menopause and sexual dysfunction here in Aspen. Why? Because there's no doctor or nurse practitioner who wants to spend 60 to 90 minutes talking to you about either menopause or sex, except for maybe a few very special people who do so. And the reason they don't, first of all, because it takes so much time. Second of all, because they have an easy out. 22 years ago, you were all told that hormones and estrogen are bad for you, which, thank God, we've worked 22 years to turn around. And thirdly, they don't really have the knowledge to do this. And part of the reason for that is that once I don't want to bias it, but once the inappropriate information was said publicly 22 years ago, medical schools and residency programs stopped teaching perimenopause, menopause, hormonal therapy. And actually one of my mentors, who's a professor of OBGYN at Mass General Hospital in Boston, and this was patients who came to me afterwards and said, I needed somebody to talk to me about this. Well, what happens when you saw Dr. So-and-so? Well, he asked me if I had any questions about menopause, and I said, well, I have lots of them. He said, have you thought about going on estrogen? She said, yes. And then he said, how are your bowel movements? Next topic. So few clinicians were ready and able to sit down and really have what amounts to probably a 60 to 90 minute discussion and teaching session about menopause. And the reason for that is when that press conference took place 22 years ago and caused so many women to throw their hormones down the toilet, for the next 20 plus years, women were making decisions out of fear as opposed to out of knowledge and data. And that's what we're here to help with today. It's my honor to bring up Phyllis Bronson, Dr. Phyllis Bronson. She's a researcher. I'm a clinician. I see patients. I read the literature. She writes the literature. And what you're going to see, this is not really going to be a how to take this or that. This is going to be highlights of important discussions about perimenopause and menopause as well. So it's also going to depend on your questions afterwards, although after Dr. Bronson gives some initial thoughts, we're going to do an interview up here. So I think you're going to find this very interesting. I'm more of a traditional doc gynecologist who gives out estrogen and progesterone depending on what the situation is period postmenopausal. Dr. Bronson is a researcher who has studied especially progesterone for most of her career. And for us traditional docs, progesterone is what you give a woman who still has a uterus postmenopausally when she's taking estrogen. Not according to the research of this incredible biochemist who feels that progesterone is so incredibly important whether or not you have a uterus. So we're going to talk quite a bit about that as well. I just want to read you a little bit about Dr. Bronson. She has a doctorate in biochemistry, and ongoing research involves studying the biological impact of molecules on mood and emotion. So it's going to be very interesting hearing from her. She lives here in Aspen. She is president of the Biochemical Consulting and the Biochemical Research Foundation. I could go on with a lot more of her kudos, but let me say that it's my honor to be sitting up here with her and invite her to come up. Please welcome Dr. Phyllis.
It's an honor to be working with you as well. Welcome, everybody. So, welcome. We want to bring alive the science where women live in our emotional, relational worlds, and also to point out things that you're not hearing at most of the talks and most of the Substacks and most of the information most of you are getting. Let me start by saying it seems like women's health became a thing recently, and then the day after, many authorities popped up, and I think it's so critical to say that everyone's entitled to their own opinions, but not their own facts. And science is built on a foundation of facts, but not certainty. So nothing we're telling you today is you have to go do this, but you should listen and ultimately gather the facts, take them to a physician you trust, and any doctor that is not open to bioidentical hormones is not aware of the most important things for women. Bioidentical means it's a molecular identification. It is not a marketing tool. And the reason it's so important will evolve during our time together. But an inaccurate opinion travels faster than the evidence needed to defend against it. And that's a lot of what you're being exposed to out there, a lot of opinions. And so I want to reiterate how wonderful it is working with Dr. Altman on this, and to tell you something very important about him. And then I want to come back to one of my two most important points tonight that I'm going to make before we sit down. I'll come back to that in a moment. But about Dr. Altman, 20 plus years ago when the Women's Health Initiative came to a screeching halt, and most of the mainstream doctors, including the North American Menopause Society, and it's a herd mentality out there. And there are excellent doctors and there's a lot of mediocrity. And I've worked with excellent doctors, and they teach me and I teach them, and I'm part of the Institute of Bioidentical Medicine Board, and the head of it, we have grand rounds every week. We discuss everything for years. So there's nothing new in this menopause discourse, and science is not bright and shiny. We're not looking to start some grand startup. There's nothing that can replace the core molecules. So Dr. Altman recognized when the Women's Health Initiative came out that it was a very flawed study, and it did a lot of harm. It did a lot of harm because 20 years later, women who had been told to go off estrogen had lost enormous amounts of bone density, and some women are more vulnerable than others. But that cannot be regained from estrogen. Estrogen has many wonderful properties, but once you've lost that bone, the women in my age range who never took estrogen are vulnerable to bone loss, it's gone. And it was because of that flawed study. So Alan was one of fewer than 100 physicians across the United States and scientists who said, wait a minute, this is not consistent with the scientific and medical data. Estrogen is really important for women. But the opinion had already flown out that it was cancer-causing. Estrogen can be proliferative, but that's not the whole story. It has many wonderful properties. And we honor that you were one of the few doctors who knew that long ago. I knew that he knew that. And at the same time, I was doing molecular work on progesterone at the University of Denver. And I want to introduce you to some of that, and then we'll sit down. So, I'm a really good skier. Well, my son Gordon, who grew up here, is a really good skier, but I'm a good skier. And what I get asked all the time, women say to me, aren't you afraid? And aren't you afraid of breaking something? Well, I think everybody's afraid about everything today. So I'm going to answer this in a context that makes sense. Yeah, you should be afraid. If you don't have enough progesterone and the right amount of testosterone, you can't build new bone. That's what builds bone. Progesterone and testosterone in the bone matrix are what will help you if you break something, and what will help you build bone even now. Because what estrogen does is it helps prevent osteoclastic resorption, bone breakdown. It does nothing to repair bone. So if you crash skiing, so what? You can heal. And I still love to ski. I mean, even in this weird year, I got 60 days. I'm proud of that. And if I get a few good turns, I love gravity, so I just wanted to put that out there. And I have this incredible new credential. I'm just going to mention it briefly. I'm Nanny Philly. That adorable little thing. And she's 4 months old, named after my late husband, Jesse Boyce, so that's Boyce. And I just want everybody to know her because Jesse was a scientific, brilliant guy, biologist, and he helped me finish my doctorate. And all my mentors in academia have been older white men. It's interesting, on women's hormones. So the thing about progesterone is it not only builds new bone, but if you only get the infinitesimal amounts that most young doctors or new doctors to this are giving 100 milligrams, you're not going to get any efficacy from that. That's only enough for maybe premenstrual tension. Progesterone is the one hormone that needs to be used abundantly because it's diverted to so many other pathways. And I will get more into that when Alan and I talk. So you need progesterone. It's the one hormone that needs to be clearly abundant to make a difference. It's also the molecule of calm, C-A-L-M. And that's the second chapter of my book, which has become kind of a cult classic. And I've been talking about progesterone for years. I've presented on it at grand rounds probably a dozen times in the last year. It is, according to the International Menopause Society, which is much less pharma motivated than the North American Menopause Society, I'm a member of the International Society, and one of the lead doctors at the conference out of Rome last year said, real progesterone is probably the most important molecule for most women across the board. Now, a small subset of women who have trouble with progesterone and they feel really groggy when they use it. We can talk about that, but the overarching majority of women get calm. Many of you, for the first time in your lives, get calm, truly, if you have enough progesterone. And so that's really important. Bone building, a little bit of testosterone will actually help you build bone, and progesterone will help you get calm. Testosterone is great for mood, but not used in the extremes that some men are using it today. It should be used appropriately, but we've used testosterone in our formulas for 20 years. So, Alan, let's sit down.
So you're going to hear some interesting information. Dr. Bronson just said that progesterone is probably the most important hormone a woman can make. I tend to feel that way about estrogen, but we certainly feel that way about both of these hormones. So let's look into this. First of all, I mentioned to you that we have so many young doctors now who know absolutely nothing about hormone therapy peri and postmenopausally because of the study that was announced 22 years ago. I call that study academic malpractice, and let me explain to you why. About a dozen menopause experts, including myself, were given the paper 3 weeks before the press conference that explained the paper. We do that because the media wants to go to experts after the press conference and get their opinion on it. So we read this paper 3 weeks before, and the information was what we call embargoed. We couldn't talk to anybody about it. We spoke to one another about it, and it turns out it was a half-decent paper which explained that there were women in their 50s who were looked at, women in their 60s, and women in their 70s. That's called stratifying data because each decade is different. Estrogen is a preserver of good function, not a repairer of bad function 15, 20, 25 years down the road so much, except maybe in the vagina. But the point was that the paper, once it stratified the data, was a reasonable paper. The problem was, and this is where the academic malpractice comes in, it was presented en masse, one group of women. And the women in their 70s who already had problems were getting negative results going on the kind of estrogen that was utilized in the study, which was oral pills, which we'll talk about as well. So that's what messed the whole thing up. And that was the misrepresentation of that study, which, as I said, caused so many thousands of medical students and training doctors to believe that hormones were bad for you. And that's what we're dealing with today. It's interesting that a patient would ask before making an appointment for a gynecologist, especially if she was interested in hormones, how old is the doctor? And that really says something when people are asking that. Now, what's happened last summer? First, let me go back to 2006, when my wife and I were invited to a very beautiful, large home here to talk to a number of women about that study and about taking estrogen and progesterone. After I gave that talk, most of these women were extremely pissed off because they heard what I was saying against what they were told. And one of them, Heidi Houston, who's a realtor here in town, stood up and said, okay, we have to lead the country in in getting this right. And because of that, a movie called Hot Flash Havoc was born. That's still available online today. You can just watch it. It doesn't cost anything. But I'm proud to say everything we said in that movie is still true today. So that's what it took to get things going. And now, as of last summer, the FDA had a meeting where they agreed to remove the black box warning from many estrogen products, which basically negates what that press conference was about. And let me point out that 22 years of data from that same study, now totaling probably over 150 papers, agree with what we were saying to correct what had been said. So now we get calls from patients who say, I can't get my patch. What do you mean you can't get your patch? What's going on is so many women have realized from the announcements from the FDA and that meeting this past summer, I'm going back on my hormones. And so many women have that it's hard to get a patch now. So that's kind of interesting. So let's first talk about estrogen. Let me ask you if you would talk about what bioidentical means when it comes to estrogen, what estrogens are there, and how do you take it? The study was done by taking a pill. I don't think any of us use oral estrogen anymore. So please, Dr. Bronson, take the floor and comment on that.
Wonderfully said. So estrogen is very important for mood, for cognition, and for many other factors. It will not build new bone, but if you are young enough, it can help preserve the bone you have. But there are pharmaceutical versions of pure estradiol, that's E2. There are 3 estrogens, E1, E2, and E3. There are pharmaceutical versions that are bioidentical. Estrace has been around for 50 years, and then today the dots and the patches, those are mostly pure estradiol.
What's bioidentical?
And the term bioidentical means exactly what it sounds like. It means the exact molecule that your body produces, replicated in the lab. It's like a 12-step process. You cannot go into Whole Foods and just buy a cream. There's no herb that can target the receptors the way the exact hormone can. Now, in my world, most of my colleagues use compounding pharmacies, which are state regulated. Every molecule is FDA approved, but the quantities are not, because every woman is different. And that's the distinction that's important to make. So, are pharmaceutical versions adequate for some women? But the overall biochemistry is lacking, because in my hormone group, what we are aware of is years of research on something called the beta-adiol function of the beta receptors and how protective that third estrogen can be against proliferation of estrogen. So that's why we use compounded.
Okay, so I don't want to confuse the issue based on the fact that there are pharmaceutically produced bioidentical estradiol products, patches, pills, which most of us don't use, patches, gels, creams. These are FDA approved. You can get them in any pharmacy. Now, there are also estrogen products that are not available, like estriol or estrone, and you're going to talk to that shortly, which cannot be purchased in a regular pharmacy, so they have to be compounded. Compounded means they have to be put together by a compounding pharmacist, which usually is quite useful when such compounds are not otherwise available. When you say the compounded estradiol is FDA approved, you mean that the molecule is FDA approved, not the product. The product is, we trust the compounding pharmacists. They make estradiol, they put it in a little squeezy thing, and it's used as a cream, but those specific products are not FDA approved. Not that the FDA approval is so important.
Well, hold on. The molecules are FDA approved. They have to be. The compounding pharmacies are all, the hormones are all FDA approved, just the quantities for an individual woman. One woman might need 1 milligram, one might need 2.4 milligrams. So that's the discrepancy.
Okay, good. That's a good explanation. Now let's talk about just briefly why the study was done using Prempro, which was an oral pill. For those of you here who ride horses, Prempro is Premarin and progestin, which we'll talk about in a minute. But Premarin itself, when I used to see patients in Boston who were on Premarin, the estrogen pill, for many, many years, I would ask how many years you've been on Premarin, which is pregnant mare's urine, Premarin, and they would go. At first I was surprised, but then I caught on. But the idea, what's the difference between taking an estrogen pill versus taking it transdermally? Now, dermal can mean skin, it can mean vagina, it can also kind of mean under the tongue. Would you comment on that? Why don't you use oral estrogen?
Well, as long as the molecule essentially is bioidentical, I consider the form personal preference overall. But every doctor on the board at the Institute of Bioidentical Medicine prefers transdermal hormones in general, and I'll tell you why. But the leading progesterone researcher in the world is a woman named Geraldine Pryor at Semcor in British Columbia, and she's a brilliant scholar. And she has used pharmaceutical prometrium, which is pure progesterone, for 30, 40 years on all her women, but a high dose at night for insomnia. And that is the known literature to help protect the uterus. The endometrial lining is oral progesterone. We're going to get into why we don't agree with all of that. But it's important to put that out there. Now with estrogen, we don't like oral estrogen because it's linked to clotting. And that's why birth control pills are such a problem for women and should not be used as hormone replacement for slightly older women, and have a lot of problems for younger women as well. But we're not advocating against birth control, especially now. But the point being, there are a lot of problems with chemical birth control. And the, what was the essential question? What is the difference?
We're looking at first pass through the liver.
Yeah, so the liver first pass, which is where hormones go when they're swallowed orally, has its own ramifications for clotting and for other side effects. But when things are rubbed into the skin, if the size of the molecule is 10 microns or below, that's what micronized progesterone means, then it absorbs through the skin beautifully. And I want to get started on why that works with progesterone when you're ready.
Let's just finish with the estrogen.
Okay. So we use a lot of different forms of estrogen, but mostly we use something called Biest, which is a compounded cream that is mostly to handle estradiol, primary estrogen deficiency, and then we always add a little bit of E3, estriol, which is not available from pharma because it's protective against the aggressive tendencies of estrogen. So bias used appropriately was something that Dr. Wickham got started years ago. Over time, we have adjusted how we dose bias to make sure that estrogen deficiency symptoms are handled, and then we add estriol. So we don't go with the exact ratios. I won't get into that explicitly right now. There is no valid hormone testing out there, except for fertility patterns. Progesterone testing is worthless, and it's the one thing I agree with the FDA on. Symptoms are key, and we'll get into more of this later, and I know you agree with me. And we have to do blood tests periodically with the women we see, because it's the gold standard in the research world. I've seen a lot of women in this valley, from Vail and Boulder, Texas, and we had to get at least annual blood tests for years because of my affiliation with doctors in the hospital. But there really is something lacking in them. They can be a mirror, but they're not a guide. And women should not be chasing numbers anyway in some false addiction.
God bless you. Okay.
And some false addiction to perfection.
This is so important. Let me explain it from the traditional MD point of view. There are many doctors who, in treating a patient with hormonal therapy, will have them get blood tests done every month to start with, later on every 3 months to see what their levels are. When I get a patient who comes having been treated elsewhere, do you want my levels? No, I don't want your levels. And the whole point here is, when you go to Bloomingdale's to try on shoes, what shoes do you buy? The ones that fit. The ones that fit. Think about this. A lot of these clinicians get these blood tests because they want your estradiol level, which to me is the important estrogen, as a traditional doc, which is different from what Dr. Bronson said, and I respect that. Because they want everyone in their practice to have an estrogen level between 90 and 110. 90 and 110. Because that way they can individualize therapy. If he's got 300 patients walking around postmenopausally with the same blood levels of estradiol, that's not individualized therapy, that's Stepford Wives therapy. Every woman is different. Every woman responds differently. Many of us will start with a relatively low dose of estrogen in a patch or a gel, whichever. After a month, get a phone call, how you doing, ask pertinent questions, then decide together, do we move up a little or do we move down a little? It's what fits, not a blood level. And when it comes to progesterone, the blood levels are completely useless.
Can I add something?
Sure.
So, a lot of people in this valley have been seduced by various holistic interpretations, and some of them can be useful, like certain supplements can be useful. But there's no valid urine test, including the Dutch test. It's just a lot of sound and fury signifying 0, just to confuse people and obfuscate, because a lot of those pathways, they don't mean anything. They don't mean anything, and they confuse people, and the pathways that are important are overruled eventually by the chemistry, by the thermodynamics, and then the kinetics, stuff I've studied for years. So I take, I have a really negative interpretation of how some of this is like the Wild West, like anything goes. You know, you wouldn't go into a wonderful trauma center like we have at Aspen Valley Hospital and say to a great surgeon like Dr. Roseberry, you know, I've been looking on TikTok, I think I could do a little surgery. And that's how it sounds to people like us out here when I hear some of what is going on. And we'll get into that very specifically about progesterone in a minute. But women need enough estrogen to handle their symptoms, but if they get to breast glandular sensitivity, they need to cut back, and usually for a short while. Estrogen is really important for cognition. As we get older, something called the FSH rises. It's a marker that you're in menopause, when that is getting above 26, and you haven't had a period for usually a year, right? But when the FSH continues to rise and rise and rise, you're in trouble. And that's what's happening to most women. The FSH, the follicular stimulating hormone, is an indicator of free radical formation in the brain, oxidative stress, and memory loss. And these things can be regained. And the hormones play a huge foundational role, including in reducing the tendency to sarcopenia, muscle loss as you get older. And I think along with certain good supplements like carnitine, and we can talk a little bit more about stuff like that if we have time, but not these endless supplement sales going on. I mean, it's too much. And it's as bad in its own way as too much pharma on the other side. There needs to be discernment. And, you know, I want to go on, but I'm going to wait until...
Let's finish with respect to estrogen, what was just brought up. I explained to patients there are two major categories of estrogen depletion symptoms, of postmenopausal symptoms. The first category, which is the earliest group, she had estrogen, now she doesn't. This is called estrogen withdrawal. It's actually a withdrawal. It's not unlike alcohol or narcotic withdrawal. Thank God it's not as severe, but it's a withdrawal phenomenon. What these symptoms are hot flashes, night sweats, sleeplessness, palpitations, headaches, mood changes, sometimes immense fatigue. Since it's a withdrawal phenomenon, if you leave them alone, and I'm not suggesting you do, but if you leave these symptoms alone long enough, they will actually dissipate because you're no longer withdrawing. Your body has gotten used to the new low levels of estrogen. None of these symptoms can kill you unless you really get no sleep, you get up in the morning, you get in the car to go to work, and you drive off a cliff. But generally, they are annoyances, minimal, moderate, or severe annoyances. But with enough time, they tend to dissipate because your body gets used to the new low level, which will be for the rest of your life. And of course, everybody's low level is different. The second category is called estrogen deficiency, meaning now that the levels are low for the rest of your life, they will remain low. Now, 100 years ago, who cared? You were making your chicken soup on a Sunday afternoon. You were schwitzing. For those of you who don't know what schwitzing is, you were sweating and it was drifting into the soup below you, which is how you got good salt into the chicken soup. And you were only going to live another 10 years, and there was nothing we could do about it at the time, and so that was it. Now, most women will spend almost half of their lives after the ovaries have stopped producing estradiol. That has consequences. Those consequences have to do with heart, brain, bone, blood vessels, skin, mucous membranes, joints, immune system, the vulva, the vagina, the bladder. Nothing important, just those things. So that's why we talk about estrogen the way we talk about it. I don't, as a traditional clinician, I don't prescribe estrogen just for the hot flashes and the withdrawal symptoms. Patients often will come in and say, you know, I've been on this for 3 years, I feel great, is it time to stop? Well, yeah, you could stop if you want. If you stop next week, what happens? You get the withdrawal symptoms again. So we have to wean you off slowly, and every person's weaning schedule is different. Some react immediately, some take a few months, whatever it is. That's with the withdrawal symptoms. So since you now understand the estrogen deficiency problems, which worsen with time, oh, I'll stay on it, thanks. That's why the medical and the postmenopausal clinical communities recommend estrogen and staying on it unless there's a reason to come off of it. Now let's switch.
Okay, before we switch, I just want to add to that.
How to talk.
That wonderful moment that you just had. There was a 10 million women study out of the NIH, while it was still the NIH, so about 2 years ago, advocating that most women over 65 should be on hormones. I may not agree with every molecule they were advocating for, but the overall premise was brilliant, that most 10 million women. So that's a lot. Okay, let's switch.
Now, I was on a panel a number of years ago addressing clinicians, physicians, nurse practitioners, etc. And one of the important questions from the group after all the lectures, were given, tell us when you tell your patients to stop their estrogen. And two of my mentors, one from Yale, the other one from Yale and then University of Oregon, got up and said the following. The one from Yale said, my mother died at the age of 94 and I went to the funeral home and took her patch off. The other one, the dean of menopausal treatment and studies, Leon Spiro, said something incredible. I tell my patients to stop their estrogen 3 years before their death. So that was a data-based answer. Because we know that when you stop it, providing you don't stop it abruptly, it takes about 3 years to lose all of the benefits that you have accrued. Okay? You want to comment on that?
No, that was perfect.
Okay.
I want to talk about progesterone.
Let's now go to progesterone. Progesterone traditionally is given to a patient who's taking estrogen postmenopausally because she has a uterus. That's traditionally.
Right.
Which includes me.
Right.
For the most part.
So,
now, the way this works, estrogen thickens the lining of the uterus, and every cycle you did that, and if pregnancy didn't come around, you shed the lining, it's gone. When you take estrogen postmenopausally constantly, even though it's much lower than the big levels of estrogen you used to make during a cycle, over time it could stimulate the lining to grow and ultimately overgrow. And this could lead potentially to precancer or cancer of the uterus. That's why the federal government calls estrogen a carcinogenic agent. It can cause uterine cancer if you take it alone and you have a uterus. However, when you add the appropriate progesterone for that reason specifically, the increased risk of uterine cancer doesn't come down to normal. It comes down to 50% less than normal. So it's actually protective against the development of uterine cancer, which is why we don't care if they call it a carcinogenic agent, because when you use it appropriately, that's not a factor. Now, I had a patient who didn't have a uterus, who I gave estrogen to, took a few months to find the best dose for her based on how she felt. And then she said, what about progesterone? I said, and you'll forgive me for this, I said, you don't need progesterone because we don't have to protect the uterus from uterine cancer. And she said, okay. 48 hours later, I got a phone call. I want progesterone. No, you don't need progesterone, but I want progesterone. And she hung up the phone. I never heard from her again. It taught me a lesson. And this brilliant researcher taught me a lesson too, and I'm now going to let her have the floor to tell you why progesterone is not only used to protect the lining of the uterus, it has a number of very important uses otherwise, and I was probably wrong in denying that patient progesterone.
But at least you were willing to think on things, which is, at least you've been willing to rethink things, which is unusual for a lot of physicians, you know. In the first year of medical school, they have Arrogance 101. A lot of them can never get past that, but there are many wonderful physicians. And I'm honored to have some of them as colleagues on my boards that I work with regularly, and they've taught me a lot too. We go back and forth. So, about 50 years ago, doctors were told, if you're giving women estrogen, you have to give them progesterone. And that's when the mischief started with pharma, because they cannot leave a good molecule alone. They have to patent it. You can't patent a biologically identical molecule. You can market it, you can sell it, but you're not going to make a killing the way you would with certain pharma drugs. So they altered the structures. You had a methyl group here and another side chain here, and then you can sell it. But this is not progesterone. These are progestins or progestogens. There are all kinds of names. You have to run an entire computer program through PubMed and WebMD to weed out all the inaccuracies where progesterone and progestins are intermixed in the terminology. So that's the first thing. And when that Women's Health Initiative study was done, the progestin that was used, medroxyprogesterone acetate, is what caused all the problems in the study. It was not the estrogen, it was the wrong progestin that is not progesterone. And at the time, so years later, when I was doing my molecular work with the former chair of the chemistry and biochemistry department at the University of Denver, there was an incredible researcher at Oregon Regional Primate Lab, Kent Hermsmeyer. And he was doing a study with rhesus monkeys. And we were working on something called the Fourier spectra of the molecule. And our data was very correlatable. But what he found with the rhesus monkeys was he was giving them pure estradiol. Rhesus monkeys and human DNA are very similar. And when he gave them straight estradiol, looking at cardiac vascular function, the monkeys were in great shape. Estrogen is great for your heart. When he gave them real progesterone, just to see if it did anything, he wasn't looking for a mood response from monkeys. No change. The estradiol worked perfectly on cardiac function. When he gave them medroxyprogesterone acetate, which is pro part of PremPro, the monkeys went into such severe cardiac vasospasms, they had to stop the study. Thank goodness, if you care about animals. And he said, wow, this is really a dangerous drug. Medroxyprogesterone acetate, the pro part of PremPro. What did the pharmaceutical companies do? They kept making the same PremPro, but in smaller and smaller doses. The molecule is wrong, it's wrong. So that really correlated with what we were finding in the difference between real progesterone and the analogs that are not real progesterone. This has produced a lot of harm for women. And then, a few years ago, the Danish government, which is extremely proactive in public health, they saw that a very large demographic of young women were having serious depression in one of those happy Northern European countries. And they went on a big investigative hunt to see why. And the only thread throughout the entire study were birth control pills. All the young women with significant depression were on birth control pills. It could be an IUD, but birth control, synthetic, altered progestin in most birth control pills is what caused the mood changes. So we correlated that. Dwight Smith, my scientific father, we correlated that data with what we were finding in the molecular world. And we published it, and there's a part of that paper on my website, Phyllis, Bronson, PhD.com, biochemical observations on women's moods and hormones. It's right there. And the webinars are on that homepage too that we've done. And so, more on progesterone. So last year there was a speaker who didn't know much biochemistry here, somewhere here. Let's just say somewhere here. And you know, it's hard when you're just out of medical school and you think you know everything. And I have 2 words that I use when I'm asked to make comments on certain sites, and they're very good words: incorrect biochemistry. And that usually shuts them up because they don't want to argue with me when I have those 2 words. And this young gal got up and said, well, you can't use transdermal progesterone because in order to protect the uterus, you have to have 6 picograms showing up in a blood test.
A certain level, yes.
And it was laughable to me and my colleagues because A, the data has clearly suggested that oral progesterone is known to be more clearly protective of the endometrial lining. But over 27 years of using transdermal, we've only seen 2 issues of endometrial problems, one of them completely minor. And that's pretty significant. The issue is most doctors don't prescribe enough progesterone.
Please talk about the calming effect
Yeah, I will.
of progesterone.
I will. So what she was saying, there was a completely false equivalence between measuring a blood level of an oral formula, which has what we call in science and in chemistry 2 half-lives. You can measure the progesterone in blood. With transdermal, when you rub it in your skin, and we have women who are really anxious, who've been able to get off benzodiazepine-type drugs doing this. They use a lot more at night. We use 200 to 400 milligrams at night. And then if they're anxious during the day, they just simply take out progesterone and use a little extra. This is a clicker of pure progesterone. And we have women who use it 2 or 3 times a day if they're going through a hard time. You can play with it. It's very safe to use as needed. So what this gal was saying obviously made me extremely annoyed. Although I'm not very reactive because I have enough progesterone. But I'm pretty chill unless I have to deal with the bully. But the point being, the false equivalence of measuring oral progesterone in blood and transdermal is completely, there's no there because when you rub it in your skin, 75 to 80% of it is almost completely converted through an enzyme called 5-alpha reductase, almost completely converted to allopregnanolone, which is the essential calming molecule. I'm not going to go into all the chemistry, which I'm passionate about, but when you rub it in your skin, there's enough left over to protect the endometrium. This is our speculative biochemistry. There's enough left over, speculative but observationally over many years, enough left to protect the endometrium, but women prefer transdermal because they get calm before they get sleepy. And we have women telling us, it's the first time in my adult life I've been calm. Progesterone is the miracle. And I'm not going to say that absolutely you'd have endometrial protection. That would not be honest to say that. I can't guarantee that. At the International Menopause Society last month, they talked a lot about a good physical exam by a good doctor. It doesn't even have to be a gynecologist. But a good doctor can look and see a lot. And if there's a problem or breakthrough bleeding that doesn't stop, then there should be a transvaginal ultrasound. It should be looked at. But it works beautifully on mood. Women get calm, and we hear it over and over and over again. Are some women really sensitive to progesterone? A very small subset, but not enough to override the overarching number that say it's been a miracle for them.
So calm is what you're talking about,
Yeah.
which is quite important, especially in this country today, where antidepressant medication is given so frequently, and a lot of the depression or mood changes have to do with the perimenopausal transition and postmenopause as well, when you can treat the source of the problem, correct the source of the problem, as opposed to treating it with some sort of harsh medication. Now, the point I just want to make, why was there these synthetic progestins in the first place? And that has to do with birth control pills. Birth control pills have to be potent enough to stop ovulation from occurring, which means it protects against pregnancy. That's the whole reason they call it birth control. And so they had to use potent estrogen compounds and potent progestin compounds, which are not bioidentical, which are much more favored postmenopausally. So that's how the pharmaceutical companies came to using something like Prempro and other combination hormones postmenopausally that were just low birth control pills. In fact, one of them is called low estrogen. So that's how we got there in the first place.
You know, I have two outstanding colleagues on the weekly grand rounds who are OBGYNs, and they've taught me a lot. They've taught me that when they have patients that are in serious trouble with endometriosis, they sometimes have to use synthetic coils. They'll use the Mirena IUD, which is really hard on mood, but it can really help with certain medical conditions. That's not my lane. But we talk about these things. And one of the interesting things that has come up lately is with Mirena coil, which can be helpful medically and can cause a lot of...
That's an IUD.
An IUD, cause a lot of mood issues, and it's something you can look up online. The Mirena crash, when women get it removed, they can often crash pretty badly emotionally. Now, the birth control pills on the market today, none of them are great. I'm not going to lie to you. This is something that needs a lot of work. I'm not sure chemical birth control is ultimately the way to go. There's so many drugs that are being marketed with false premises, including one using a doctor who spoke here last year, Duavi, is on the market. And it's just kind of a weird formula, but they're pushing it and pushing it and pushing it. And, you know, it's birth control that it's an estrogen and a synthetic progestin, and it's a weird combination. I don't remember the formula, but the side effect list is far longer than the pro list, but it's being pushed and pushed and pushed right now, so I'm not too thrilled with that. The progesterone issue is that the head of our group last month said what he's learned from me and my colleague Carol Peterson, who's a phenomenal progesterone person, originally one of the early pharmacists at Women's International Pharmacy, which is now part of Belmar, which we use. And he has said he's learned so much from the two of us, including the webinars we've done this year, that he has realized that women need enough progesterone until they get calm. Until they get calm. And if they're drowsy the next morning, cut back. It will not hurt you. Now, what can happen is if you're low in estrogen and you use too much progesterone, mood issues can recur. And so you use more estradiol that day. We give women who are vulnerable to flat affect depression a little tube of extra estradiol. And then for anxiety, nothing beats pure progesterone. These are clickers. And you just rub it in your skin. I mean, I used it before today.
I need to respond to that respectfully. Most of my patients don't want to spend the day thinking, do I need more progesterone or do I not need more progesterone? Now, if they're really having trouble and they're not calm, I try to calm most of my patients. and most of them are calm, it's something you need to decide whether you're going to take more or less, and most of my patients don't want to do it that way, but I have deep respect for this. Now, let's go to something that Suzanne Summers said.
Before you go there, may I add something?
I want to add something. So most of the women I've worked with for many, many years, I don't take new women now, but I still see the ones we've seen. We make a morning formula and an evening formula, and then we only use extra as needed. The morning formula, I just want to clarify this, has 2 estrogens, E2 and E3, progesterone, testosterone, and then due to FDA regulations now, we have to give them separate DHEA and pregnenolone. I'm not going to get into that now. And then we give them a night formula with estrogen, usually a little estriol, and progesterone. We only have them using extra progesterone on an as needed when they're going through a lot.
And part of the reason to use it twice a day is because the levels go up and then go down and need to be replenished again. That's why many clinicians now use patches, which help to maintain a level throughout the 3.5 days that you're on the patch, which brings me to something that Suzanne Summers made very popular, and you still hear about it. That is, I want to cycle postmenopausally just like I did before I had my menopause. I want to cycle like I'm 28 or 32 and have a bleed because that's natural, because that's good for me. We disagree with that. And part of the reason, and Dr. Bronson will talk about it from a cycle point of view, I talk about it from a cancer point of view. Before you had your period, what happened to your breasts? They got sore, they enlarged because they're trying to get ready for pregnancy. How do they do that? Well, the breast cells proliferate, they multiply. Some people say they divide. Instead of 1, now there's 2. Multiply, divide. There are just a lot more cells there getting ready for the potential of pregnancy. So you have proliferation of cells. Then you have your period, no pregnancy, the breasts go back down, and they start up again. We've learned something over the decades. When you proliferate breast cells 12 to 13 times a year for 30 plus years, you run the risk that one of those proliferating cells will mutate and go on to become a cancer, a breast cancer. And you may not find that for 15 to 20 years. My point is, you don't need to proliferate breast tissue 12, 13 times a year postmenopausally. You just need to take what you need, whether it's lots of progesterone because you want to calm, or whether it's estrogen plus progesterone. The whole point is there is no need to cycle like Suzanne Summers wanted lots of people to do. Now, Suzanne Summers did some good for women. In the beginning, when this disgusting study was misrepresented, she came on and said, if you use natural bioidentical hormones, you won't have to deal with these problems. Well, needless to say, it was good for women to hear that this was not an open and closed book. Have a comment?
Well, you know, in terms of evolutionary biology, in cultures where women had fewer periods and they were pregnant more often, it was far less cancer. And Suzanne Summers, I agree with Alan, she brought some things to light, but she had no scientific ability, nor did T.S. Wiley, and so women were actually misinformed, incorrect biochemistry, and it didn't end well for her. Anybody can get sick, I'm not blaming her, but I think the fact that she was misguided has prevailed. There are influencer doctors online. There's one who keeps talking about cycling. We've counted her strongly. but they just keep believing in their belief rather than facts. And so it makes no sense to have a false period when you get older. It doesn't make any sense.
So let's finish our part of this interview talking about the perimenopausal transition. This can be a very rough time for women and for their clinicians, because perimenopause to me is this. That means sometimes the hormones are fine, sometimes they're too high, and frequently, every time they drop, that's the withdrawal symptoms that I explained before. So you could go 6 months with no period, with some hot flashes, night sweats, and problems like that, and then start your regular period again. That's how confusing the perimenopausal transition can be. I say to my patients, if you're 35, you're perimenopausal. I don't need a blood test. I don't want a blood test. It's the beginning of the transition. Dr. Bronson even goes further and says 25, correct?
Well, late 20s, I think.
Okay.
Late 20s, your progesterone levels are starting to gradually decline. And then later, estradiol declines more rapidly.
So when you treat postmenopausal women, the ovaries are no longer producing estrogen or progesterone. When you treat perimenopausal women, and by the way, if you explain perimenopausal transition to most patients, at least 50% will say, thank you very much. I thought I was going crazy. I thought I was dying. I thought I had cancer. You've reassured me. Goodbye. I'll come back if I need something. The other 50% will grab me by the throat and say, that's nice. I'm glad to hear it's normal, but you better damn well take it away.
Yeah.
So then you get to the problem. What do you do perimenopausally? If you give estrogen, remember, the ovaries are still making estrogen, albeit erratically. Take it.
Well, we started many young women on progesterone. Usually it was 2 weeks prior to their cycles starting, but some of them felt so much better they would start it even a week early and beg for it. So it's totally fine. Your cycles may get altered. But before we start to wind up, I want to mention a couple of really important books. My colleague Jeffrey Dash, D-A-C-H, you can look him up online, jeffrey-md.com. He wrote an incredible book called Bioidentical Hormones 101. The revised edition came out a few months ago. It's brilliant. I'm mentioned in there somewhere. But the book itself,
It's a good book.
it covers so much of what we're talking about today. And just an interesting thing for you to know, Jeffrey Dash was a very accomplished traditional physician in Florida, and he was looking for what he wanted to do next about 30 years ago. And he came to our orthomolecular conference in Canada, and I was presenting on hormones. First time he ever heard of hormones, and his whole career has become about hormones. So for anyone looking for help, his specialty now is helping women who have been diagnosed with cancer, and he has some incredible protocols. So it's worth knowing about him. He's also listed on my contact page on my website. And then the other book I want to mention, and I don't love this doctor, but the book is important. It's called Estrogen Matters by Avram Blooming. And it's not a perfect book, but there's some very important parts to it. And I like the first volume better than the second. So those two books you should be aware of, and my book too. I mean, Moods, Emotions, and Aging is very readable, and it's pretty much a classic.
Now, we could go on for the next 3 days discussing this, but we're not, because we can't. So I'd like to open up the floor to questions, if you would. We have one young lady who is one of our contributors to keep this going, and we appreciate that. Please make your question a question.
Thank you, Alan. Thank you for putting this together. You briefly talked about testosterone. I'm already on the patch. I'm on progesterone. I'm not sure enough right now. I'd like to know how testosterone fits in.
It fits in a number of ways. I mean, first, what I mentioned earlier is that it's part of the bone matrix. It's really important for building bone even as you're older, which you're not quite yet, but you know, you're getting there, right? So for any age woman, it's important. It's also very significant for mood, and not just libido, but for mood. Now, along with estrogen, we've used testosterone for years. There's an influencer doctor out there acting like she just discovered testosterone for women. Not true. The things that we're talking about, we've been working on for years. There's no new menopause. There are things that have been out there for years that are coming to light, but they're not new. Testosterone is very helpful. I wanted to say something about men and testosterone. It's very important. We had a speaker here brought by Alan last year, Abe Morgenthaler, and he was brilliant on why men may need testosterone as they get older, but not these excessive, endless working out guys like that's magic bullet. There is no magic bullet for any of us. And the problem, if younger guys start testosterone too young, am I allowed to say this, Alan? They can shrink their balls. And so,
Can you put your mic closer and say that?
They cannot. If guys just want to be like, you know, listening to influencers, and that we have, you know, influencers on the male side on, you know, steroids, just like on the female side, and it's too much. And if they start it too young, they can shrink their testicles and lower their sperm count, actually.
So let me add something, since you just brought that up, and I appreciate the question. There are clinicians who start a patient postmenopausally on estrogen, progesterone, testosterone, and then work from there. There are other clinicians who start patients on estrogen postmenopausally, work with them for a few months, figure out the dose based on what fits, and then after a few months add the progesterone, and then after a few more months, if there's still a libido or problem where she wants testosterone, then adding the testosterone. Because when you give three things all at once and there's a problem, which one's it coming from?
Well, Alan, we listen to symptoms, and we have long advocated. I mean, I have total respect for your approach, but I have a little more for mine with this, because we have long, with this particular thing.
Oh, this is important.
Mean, since the days of Dr. Whitcomb, I mean, we have long advocated for our morning formula having estrogen, testosterone, and progesterone. And women have thrived. I mean, the overarching majority have thrived.
Absolutely.
And if they have symptoms, then you adjust.
Which you adjust if they have symptoms. If you're on three things.
If they have breast tenderness, we cut back on it too. If they have too much libido, which I've never heard of, in that slightly older age range, we can cut back on testosterone. We don't overdose with testosterone and estradiol. We use the appropriate amounts. The only hormone we go really high on is progesterone, because not only is it critically important, but progesterone dampens adrenaline, and it dampens excessive
cortisol.
Well, cortisol, but cortisol is actually made from progesterone, and if your cortisol is very high, you're low in progesterone. And unlike what most of you have heard about cortisol spikes, that happens, but that's not the real core issue. The core issue with cortisol is low cortisol across the board. It's a major factor in inflammation, which we hear so much about today, and I could talk about that for a day, but you want to have a good level of cortisol.
I was wondering, the next new thing for estradiol is you can't take it because you had a blood clot. And where did that come from? I have had to beg since I was 26. I've been on estrogen, and every 10 years, I have to either go to Mexico or find, it's ridiculous.
I agree.
It's a very good point.
Very.
Part of the reason we don't use oral estrogen is because when you swallow estrogen, it goes into the stomach, then it goes into a separate blood flow system to the liver. In the liver, oral estrogen increases the production of blood clotting proteins. This is why birth control pills increase the risk of blood clots. It's why oral estrogen postmenopausally increases the risk of blood clots, which include not only blood clots, but pulmonary emboli. When we use transdermal estrogen, it goes directly through the skin into the systemic circulation. It does not go first pass through the liver, and therefore it does not increase the risk of blood clots. That doesn't mean you can't get a blood clot when you take transdermal estrogen. Everybody's got their own risk of that, but it doesn't increase that risk.
Right.
So in patients who have a history of something, we always check their clotting factors, see if it's something genetic, but generally we switch them from oral to transdermal, or if they want to go on with that history and we look into it and we see that it's not something that transdermal will increase, we will offer them transdermal. So it's a very important question.
Very important. And can I add to that, Ellen? It's really important what you're bringing up, and you're brave to bring it up because so many women suffer when they've been denied estrogen. There is nothing in the traditional literature suggesting that transdermal estrogen causes clotting. And my former medical partner after Dr. Whitcomb, I worked for years with Chris Martinez, who was an ER doc. He just retired. It's wonderful. And he would tell women who had a difficult medical question, whether it was cancer or clotting or heart disease, he would focus on quality of life. It was always his response. And so, you know, there's nothing in life that's totally safe, nothing in medicine that's totally safe. And ultimately, the purpose of my work has been to help women trust their deepest intuition. And the more balanced you are hormonally, the more you can do that. And trust yourself and find doctors you can talk to.
Question here.
Those of us who are of age that we went through menopause about the time of the study.
Yeah.
Will you comment on beginning hormone therapy significantly post-menopausal?
I would. I'd love to, because I'm in that age range too, and I've taken them for all these years.
Yeah, but if you haven't taken it.
Sorry.
I know. I'm talking about me first. I think for most women have not been taking them to many of their detriment. We have many women who have started them later, and it's perfectly safe to start them later, but they should be started slower, except progesterone. It's like starting a rusty car. Would you agree, Ellen? You start a little slower, but we have plenty of women that we've worked with in their 70s and 80s who are starting hormones. And we have a client from Vail, a fabulous woman. She was in a lot of trouble with depression. And she was afraid of estrogen. She had a cancer history. And Chris Martinez said to her, let's just start testosterone and progesterone. She really did well. And then 6 months or so later, she was still struggling with depression. And Chris said, you're never going to get out of this without a little bit of estrogen. She's older than you. She's doing brilliantly. She's just one of many. We've started many women who are older, and they do beautifully. They will not regain lost bone density because of that flawed interpretation. But you can.
Well, the question was really important because the major menopause society, the North American Menopause Society, said that if you go beyond 10 years beyond your menopause, it's dangerous for you to start. Now, that data was based on the study done with Premarin and Prempro,
Exactly.
oral estrogen, which increases your already at that age slightly higher risk of blood clots, and then you just increase it more with an oral pill. So the question is incredibly important. Most of us who know this science will start a patient regardless of what her age is, providing she's got some reason to go on it, and that's in the discussion that we sit down and talk about. Question? Well, why don't you share?
Hi. I have a question about testosterone for me. I used to have a lot of energy to work or play all day and night, and I'm 65 now, so my energy level has gone down substantially, and it affects what I would like to be able to do. Also, my partner thinks that my libido is lower, so I'll give her credit and say, okay. But I traditionally had a high PSA. It's in the mid-4s. So I've had it tested regularly, including needle biopsies, and it's never been a problem. But I've heard in the past that if you take testosterone, it may be an increased cancer risk, which I'm afraid of. So I wonder what to do for me in this circumstance.
I love your courage, and you have a fabulous wife. Would you start with?
Put it closer to your mouth.
Would you start answering that now?
Sure. Abraham Morgenthaler, who is one of the brilliant urologists in this country, took the only study out of France that suggested that it showed testosterone increases risk of prostate cancer, and over 20 years at Harvard completely disputed it and proved that it was not really true. So he was here last year, and he spoke. You can look that video up on our website and really sit and listen to what he said. It's very impressive, and it's full of knowledge and data. That doesn't mean that if you have a prostate cancer, it might not stimulate a little bit, but the research on it causes prostate cancer is not necessarily true.
And
We do know that men with low testosterone have an increased risk of prostate cancer. People with high testosterone shouldn't be taking testosterone. People with normal to low testosterone, there's physiological reasons to take testosterone.
I would also look in the book I mentioned, Bioidentical Hormones 101, he writes about it too. Getting your hormones balanced is not going to hurt most people at all, it's going to help them. I mean, think about the fact that most women who get gender cancers are older when they have no hormones. And I'm not a specialist in men because I worked on mood with women for so long. And if you ask a typical guy in those arenas about mood, they'll say, well, I told you 3 weeks ago, and it's supposed to not change. But in terms of testosterone for men, it's wonderful, but not at the Joe Rogan kind of dosing, I don't believe.
Now, we discussed before that men taking testosterone, there is also, especially as they get older and continue taking testosterone, some of these men have enough of an enzyme that testosterone gets made into estrogen, estradiol, and then we have the problem, please excuse the term, of man boobs.
Alan, I don't want to forget to mention this. There's a website, Progesterone for Men, and we use my medical partner. Well, it's really important because progesterone acts as an aromatase inhibitor instead of the chemical aromatase pharmaceutical versions, much safer. And
That's the enzyme.
Yeah, my colleague has a website, the Wellness by Design Project. There are great articles out there, and some on men. It's worth looking there. And so Chris Martinez, for years, put a little bit of progesterone when he gave men testosterone. The other thing that can really help energy is DHEA for men or women. We prefer transdermal, and there are a number of reasons for that, instead of just going in the health food store and buying a pill. But you have to find a way to get hold of those things. I highly recommend looking at Carol's website, because the Wellness by Design Project, she has resources out there. I don't use over-the-counter progesterone, for example, but she has one that she says has been great for people who don't have access to compounding. And it's a company called ONAS, and it's gotten some great reviews. So I'm just putting that out there, and she talks about testosterone too. I would look into it. I'm not a specialist in men, but I've seen men thrive when they use it appropriately.
We do need to stop.
Is it late?
We are going a little late. I just want to comment on the fact that just about no one has left. Thank you, Dr. Phyllis Bronson.